Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, your host for today. I'm in the studio with Dr. Mickey Daugherty and Katie Mueller, APRN from the Division of Urology at Cincinnati Children's. Today's discussion is on bedwetting, something we see very commonly in our offices. I talk about it almost every day in the office. So we're very appreciative to have these experts to give us a little more insight. First, I'd like to welcome Dr. Daugherty and Katie. Love to have you here. Before we get started, can you tell us a little bit about yourselves, about your background, about your interests?
Right. So I am from New York originally. I came here in 2018, and so now my family's lived here for the past 6 years or so. It's going on 7 years. I'm a father of 3 young kids. They're 7, 4, and 2 right now. We have a dog, a golden doodle. My wife works at UC also here, so all our family is raised here, and that's pretty much it.
Great. Welcome.
I've been with Children's for 23 years, with urology for 12 of those, and I have 4 kids that keep me busy outside work.
Absolutely. Well, today we're going to talk about bedwetting. I thought it would be helpful to just kind of start talking about normal development when it comes to daytime potty training, nighttime dryness. What should we be advising our families? Like, what is normal? When I have the mom of a 3 or 3.5-year-old come in and talk about how they're still having accidents at night, what should I tell them as far as what to expect?
It's a great question because there's not really a very simple answer for that either. So when people come in and they ask about what's normal from a potty training standpoint, you have a huge range. Sometimes you have a 2-year-old that might get potty trained. You might have like even a 4 or 5-year-old that gets potty trained around that age, 4 or 2. Those are both still normal. And so a lot of it's depending on the child, the family dynamic, and how things are going. There's a lot of variability from there. So things that you're looking for is just when does the child seem that it's ready. Sometimes we see when families try to impart toilet training a little bit earlier and the kid's not ready, it's a much more stressful situation for the family. And a lot of it just takes a lot of time. So it just sometimes, even with my own kids, we started potty training and they just weren't ready yet. And so it didn't work successfully. We just gave it a break for a little bit, and a couple months later tried it again. So it can take some time.
Any readiness cues that you can share?
What do you think?
Sometimes they say, like, when they can walk upstairs, like each step at a time with a new foot, that's when they're ready. They can kind of toilet. They can get their clothes up and down, things like that. They don't really need much help. But I think a lot of it is determined, too, by if there's any, like sensory processing or developmental milestones that were delayed. Then sometimes toileting is also delayed. And so we'll see a lot of that kids aren't developmentally on target, and then parents are worried because they're not toilet trained. And a lot of times it just takes a little bit more longer time.
Okay. Sometimes even like families will say, well, they can tell you when they have pooped or when they've peed. That normally is not the best cue for it's ready to potty train, because they're probably just sensing that they're wet in their diaper. Not that they peed, it's just they can feel that there is pee there. Mm-hmm. And that's sometimes the thing is just trying to say that they may not be ready yet, even though they can tell you they have pooped or peed. The rest of the part of toilet training may not be there yet.
Okay. So at what point, today's topic is specifically about nighttime. So at what point would you start to advise a family that we need to look more into this? We need to, start some even low-level interventions?
I view it as almost very rarely, honestly. Okay. So the biggest thing when we talk about bedwetting with families and they come in, a lot of it is reassurance. This is an extremely common issue that comes up. Even from like an incidence standpoint, if you look at a 5 or 6-year-old, it's like 10 to 20% of children will have bedwetting at that age still. So telling even the child, in your classroom, there's probably 4 or 5 people that have this same issue, and they don't talk about it. But it's very common. It's not something that normally is a medical problem related to it. This is just they're not ready and they haven't been able to do the nighttime dryness yet.
Yeah, and when I see a family, oftentimes I'll say, are we limiting fluids? Little things like that. A lot of these kids will go to bed with a sippy cup, and you're like, well, it's hard to be dry when you're drinking a cup of water all night long. And so those types of things, making sure we're stopping after dinner, making sure we're drinking well during the day, just those types of things that a lot of times these kids will obtain nighttime wetting just on their own from that standpoint.
Okay. So when we're asking questions or talking, actually really the families are coming to us with these questions. A lot of times family history kind of naturally just comes into the conversation. Dad wet the bed till he was 13, uncle wet the bed till he was 14, grandma did this. There's always a discussion of who else in the family has had this. So anecdotally, I feel like that is relevant, or at least it's telling. Is there any data, or do you guys have any of your own experiences through your clinical work to talk about family history and kind of predilection within families?
So there's definitely a very strong family history component that's not really well understood. If you look at if someone has like no family history, it's I think roughly like 15% of children have bedwetting from there. But if you have a parent that had it, it's like 50% of their children will have bedwetting.
Okay.
If it's both parents, it can be up to about 75%. But this is not great data from there, but that's what we have from an incidence standpoint for it. So I use it as a way to just acknowledge that there is a family history component to it. I've seen anecdotally, but there's not really anything I've found that's great data behind that. Is I often tell people if you had bedwetting until you were 15 or 13 or 14, it may be the exact same for them. There's a very similar age that they grow out of it. I don't have a good reason for it, but we do see that often that if you had a later resolution of bedwetting, it's more common that it's going to be a longer time for it to resolve.
Yeah, that's how I approach it too. And I think sometimes those are the harder ones because when they get to be 15, they certainly don't want to be wetting the bed. And so I think setting those expectations early that if your dad did it till he was 12 or 13, that might be the age that you outgrow it till.
Yeah, and I certainly see in my office a lot of kids who are deep sleepers.
Yeah.
The kids that, the mom says, oh, I can go in after he falls asleep and turn on the lights and put his clothes away and clean his room, and he doesn't wake up. Like, those kids tend to be later to be dry at night. To me, that says, their brain is just going into such a deep place of sleep. Is there anything we know about that regulation, that communication between the bladder and the brain that, I could, speak a little more eloquently to my patients about, other than just saying they're a deep sleeper?
Well, part of that just comes in is that normally you have to have that sensation of feeling that you have to go that will then wake you up to then say you have to go to the bathroom. So if they are a heavier sleeper for various reasons, you may not know why, but they're able to sleep through significant stimuli that is not going to wake them up. Why would a full bladder wake them up then if you can't have like blaring music and that doesn't make a difference from there? That's also a very hard thing to fix for people, and it's just you don't have a good solution to it. But if they can't wake up with alarms, different things, it's very hard to say that a natural sensation you're going to feel is going to wake you up also. It's just trying to, again, manage expectations with the family that this can happen. They'll eventually grow out of it over time as they learn that sensation. That's where some of the therapies can help with that.
Okay. So when a family comes in, usually I will start to dive in more to the bedwetting questions if it's bothering the kid. If you have an 8-year-old that it's not worrying them, they wear their pull-ups at night, they're not doing sleepovers, that's usually not an issue. It's when they get a little older, when they're going to camp, when they're sleeping over, that seems to be the social pressures that push kids to want to be dry at night. So when I have that situation, what kind of questions should I be asking the child? What kind of questions should I be asking the family?
So I always ask, first thing is like, do we stop fluids before bedtime, or are we drinking up to bedtime? Most kids also don't pee before bedtime. And so if they're not emptying their bladder before bedtime, they're going to fill that bladder and it's going to empty overnight when they're not able to be awake. So I tend to kind of get into those little things, like how much are we drinking during the day? Are we using the restroom during the day on a regular interval? I also ask about, are they eating lots of salty snacks or lots of dairy before bed? Things that may kind of tip them over to where they're going to wet overnight. And so a lot of our visits, I feel like we dive into that HPI to kind of figure out what is changing. Some families are like, they drink overnight. They sneak water. And you're like, well, I can't really fix that, right? So that's when those limits come in handy.
And then even seeing like what their schedule's like. I mean, if they're playing sports and sports go till late in the evening and then they need to then drink after practice or a game, that's also very hard to correct because if you're not going to limit fluids, there's a very low expectation that bedwetting is going to improve on its own. Seeing like how often it's happening. So is it every night of the week? Is it only sometimes? Is it a large amount, a small amount, or just some of the history of that standpoint can help kind of guide some things you might use either situationally from a therapy standpoint or to kind of help prevention moving forward.
Yeah.
Okay. And when we're asking these questions, are there any red flag symptoms, things that will kind of take us out of that normal developmental bedwetting into something more maybe pathologic?
I think the biggest thing to focus on initially from a red flag is their daytime urinary symptoms. So when you're talking with families and they come in and they say they have bedwetting, but then you ask them more questions like, oh, we also have urgency and frequency during the day. I tell families we will do nothing with bedwetting until the daytime stuff is better. And so that normally is, those have to be focused on first. If things are not better during the day, I wouldn't expect their nighttime to get better in any way. So trying to just screen from how is urination going on during the day? Is there any history of UTIs, especially like febrile UTIs would be more of a concern that there's some possibly underlying anatomic problem or something wrong with the bladder that could be contributing to that as well.
What kind of things would that be?
So if you have a febrile UTI, that'd be more concerned that there may be something like reflux, where urine is going from the bladder up towards the kidney. That gives it, where there's a fever with it associated with it. That can be something that can be addressed or be evaluated beforehand. Again, because if the normal voiding is not where it should be during the daytime, the nighttime stuff is not going to be there yet. And so that's normally, if you're looking from a fever with a UTI, it's not like a low-grade fever like 100. It'd be like you're looking for like 102, 103, like a much higher fever from that standpoint. Other biggest thing we probably look at is constipation.
Yeah, that's a big one.
Okay, so like in that regards, what kind of questions do you ask about, bowel habits, and how does that play into nighttime?
Yeah, and no one's ever constipated when they come in, right? They're always going to the bathroom. But sometimes you'll ask them, like, are your bowel movements large? If they're large and parents are like, yes, absolutely, then that tells me that rectum is full. And so if your rectum is full when you're asleep, how is your bladder supposed to expand and hold all the fluid it needs overnight? And, a lot of the things that I do is if I start them on a medication to improve their bowel habits, I tell them we got to continue this. Just because we do it for 3 days, 4 days, it's not going to fix it long term. And so I always ask that, are they going every day? Do they have any straining? Some parents will say, oh, they're in there for 30 minutes. Well, that's not typical. Most people should get in and get out. But I think constipation is probably one of the number one contributors on why kids can't kind of outgrow bedwetting sooner.
And that may be just bias from being in neurology, but
Sure.
basically every kid that we see, we view them as being constipated for the most part.
Okay.
No matter you talk with families, they're like, well, they poop regularly. You can have functional constipation where you may poop every day, but there's certain components, whether it's large caliber or it's just that they have like basically balls of stool that come out, which is a sign of actually fairly significant constipation if they're going every day. It's trying to manage that expectation, trying to get the constipation better managed, can have a considerable improvement in their voiding symptoms both daytime and nighttime.
Okay. And then boys versus girls, kind of is there a prevalence one versus the other?
It's definitely more common in boys. Same data from there, but like about 3 times more common in boys than girls. But that may be that some of them don't seek treatment or don't seek help with this. If they don't need it, they might not want to talk about it either. So that you see probably a more predilection for boys, but you manage them the exact same, boys versus girls.
Okay. And moving on to physical exam, is there anything on a physical exam that, would be very concerning? What kind of things should we be checking in any kid with nocturnal enuresis?
It's just that you go through like a normal exam that you're looking for. Is there anything grossly anatomically abnormal from their urinary tract? So for boys, do they have a smaller meatus that can have some urinary symptoms with it as well that can contribute to a not happy bladder for the most part? You want to look and see if there's anything from like a gait as they're walking in. Does that seem abnormal? Is there anything potentially as like a sacral dimple or anything abnormal from their back that may be a sign of something to look into more from a nerve standpoint? Most of these, though,
It's like an occult spina bifida.
like a tethered cord, sacral dimple, something like that you might see. But again, those are such a varied presentation that your screening thing might be like that. The butt looked a little bit different. There's a little bit divot that's there, and that's something to maybe look into potentially. But that's very rare to see that as a screening from finding this. Most of the exam is completely normal for these. And it's just talking with families about what their symptoms are. It's more a constipation, bladder-related thing more than anything else, nothing anatomic.
Okay. And any labs we should be ordering on the outpatient side or on the primary care side?
No, even for this,
Okay.
like
Not even a
imaging-wise.
UA or-
So I don't think the urinalysis would have much benefit to it. I mean, if you have someone that has night wetting for 3 years, even if the UA is positive, if they have no symptoms from it, we don't normally even treat them sometimes too. So again, you're not going to have an infection that lasts for 3 years that was never treated that caused these symptoms from there. So if they come to clinic, we normally, for a primary bedwetter, we don't even get imaging for this. If it's just an 8-year-old coming through, it's just more alive. It's just counseling the family and talking about the things that we can do.
Yeah, I think some families, when they come in, they're worried about diabetes, right? They hear that. So sometimes a UA to just make sure that's normal is okay. But I think we try not to get into the habit of testing UAs often because then we find these positive cultures that do we treat, do we not treat, and then families sometimes will call us and say, well, they're wetting again. It must be a UTI. And you're like, well, if it's E. coli, are they constipated? And that's what's kind of causing that increased bacterial load. So I know we try to avoid those urine tests in clinic because sometimes you get backed into a corner of, I want this treated, and we may not want that to be treated.
Okay. And you mentioned, primary nocturnal enuresis. Let's touch briefly on secondary nocturnal enuresis. So how is that defined? How does that change your guys' approach if a kid was dry for a while and now they're having accidents again?
So when you try to differentiate between primary and secondary, when you're looking at secondary, they have to have had a 6-month continuous span of being dry overnight. So they have to have they were good for 2 months, then it came back. It's 6 months, so it's a considerable amount of time, then they have wetting again. And that's the difference between primary and secondary. Most of the evaluation is the exact same from management for primary versus secondary, but you want to see, is there something changed in their life? Is there some different stressor? Is it they've changed schools, they moved, something changed different from that standpoint? Or is it maybe their constipation has gotten worse all of a sudden? So they were fine, then it got worse. From sometimes the secondary bedwetters, we will sometimes get imaging then, just see is there something to pick up from the bladder or the kidney standpoint that may be a predisposition to that. That might be why it happens as a secondary standpoint.
So after we've talked to the family, we've talked to the child, gotten our history, we feel pretty confident this is more just straightforward primary nocturnal enuresis. What are some first steps that you guys can recommend for our primary care provider?
So I always recommend make sure we're stopping fluids before bedtime. I say 2 hours. I also do make sure that they're drinking well during the day. A lot of kids don't drink a whole lot. They come home from school and they down 3 bottles of water, and you're like, well, it's got to come out sometime. It's going to come out either in the next hour or overnight. So I think making sure they're having daily bowel movements where they feel like they're emptying well. And then also sometimes we tell them to avoid like the 4 C's close to bedtime. Caffeine, carbonation, citrus, and chocolate, because sometimes those can be bladder irritants. Bladder may squeeze a little bit overnight and them not know that signal.
Yeah, and the other thing is just reassurance. I mean, just talking with families and the children, it's very normal. Mm-hmm. And there's nothing that's wrong. There's nothing that they did wrong. They're not they can't control this right now, and that's okay. And I think sometimes the reassurance is the biggest part of the counseling for this, and more than everything else from there.
Okay.
Yeah, and just setting expectations that it doesn't usually get better overnight. This takes time.
If they've done those things, though, and the kid's really just frustrated, having a lot of psychosocial stresses about it, self-esteem issues, limiting their activities, are there any, second or third line interventions, before we send them to a urologist or a nephrologist? Anything else that you guys typically recommend in your clinic?
Yeah, I think first line, we always recommend a bedwetting alarm because that's the way to kind of get the brain to be aware of an external stimulus that it's happening when your bladder's full or you're emptying. I recommend that on everyone. And I always tell my families, guess what? I'm going to bring this up every visit you come back to me because this is the way we can help them kind of outgrow it a little sooner, per se. Sometimes we'll use desmopressin or DDAVP in social situations, which I always tell families it's a Band-Aid. There's a high chance of relapse on that, or reoccurrence. So in that standpoint, we can try it and see if it works. Some kids, it makes a huge difference. Waking up dry in the morning makes their whole day run smoother. And so in those instances, I tell those families, great, let's use it. We can use it every day. We can use it just for special situations. They're going to camp. They're going on their Washington, D.C. trip, things like that. But I just want them to know that it's not going to fix it. It's not going to help them outgrow it sooner. So this could be a long haul for this.
And then even with starting DDAVP, we normally start with like a 200 microgram as the dose, but they can titrate up to a max of 3 of those pills. So it's still, when we start the medicine, as we mentioned, is you can try it and see. You need to restrict fluids like Katie was talking about before, because if they still drink, it's not going to work anymore. And I tell families, all it does is makes you make less pee at night. Mm-hmm. Doesn't fix the problem. So when you have people that eventually stop medicine and it's gotten better, it's not because the DDAVP fixed them, it's because they grew out of it in the first place. Okay,
but you guys feel like the DDAVP is a safe intervention for a kid that needs that step?
I think as long as the kidneys are, like, they don't have any baseline, like, kidney dysfunction where they have a concentration defect or anything from a fluid status that would be an issue, it can be very safe. Okay, good. And so we will use it situationally of, like, if you know you have a trip coming up, or from a sleepover, you can try and test what dose would be appropriate from there. to help. But again, I emphasize to families it doesn't fix the problem. It just makes it maybe help in those times when we really harp on the alarm. That's the one thing that has been shown to get things better faster.
And I want to talk more about the alarm, because when I bring that up in the office, parents are always looking at me like, this exists? This is a thing? So can you guys talk a little bit about what they look like, how they operate, where parents might even find them?
Yeah, we typically recommend, I always recommend just Amazon. That's typically where you can find the cheapest ones. Insurance doesn't typically cover them. I think there's like a bedwetting store that you can get them from too. But basically it's got like a sensory that they put kind of on their underwear. And then once it detects moisture, it starts alarming. And the number one thing we see when they come in is like, well, they don't wake up to it. I'm like, well, yeah, because they're deep sleepers. They're not going to wake up to it. But continual use of that, and we talk months of using that eventually they will. And I always tell families that it's a family affair. It requires a parent to really try and get that kid out of bed, get him in the bathroom, and kind of get him awake enough that they know what's going on, all while that sensor's going off, which is very tough, when there's younger siblings in the house or dogs. Animals tend to not like those loud alarms in the middle of the night. So families just, it's hard for them to be able to do that every day. You also are interrupting their sleep patterns, right? Because they're waking up. It could be twice a night. You don't know how many times they're urinating overnight. So, but I always recommend them.
And then harping on the point that it doesn't stop them from wetting.
Correct.
It only triggers and alarms when it actually gets wet.
Right.
So sometimes people will say they stopped it because it kept going off because it didn't prevent the wetting. We still had the wetting. So it's just how it works. It's a negative feedback. You get that alarm is what wakes you up because it got wet. So you learn what that sensation would be. So that's how you wake up. But it takes a very long time. So it's it's a several month process. It's going to wake the child up. It's going to wake everyone in the house up for it too. So sometimes people will stop it sooner because it wasn't right for us. We just couldn't do it at the time. And that's okay.
Yeah.
Again, this is just something that can help. But I sometimes we'll see as the kids are getting older and like they don't wet the bed maybe every night, but it's every few nights or maybe a couple nights a week. I'm like, that's a great time for an alarm because it's not going to go off every night. You don't want to use a medicine like DAP every day when you wouldn't need it half the time anyway. So that can help as they're starting to grow out of it more. It can maybe expedite that process even more.
And at least the feedback I've gotten in my office is because they make them that are wired and there's ones that are wireless. The kids that I've seen, they seem to do better with the wireless ones. They're more comfortable. They don't get tangled up in the wires.
Yeah.
But I've also had kids just tell me that, or the parents tell me that they think the kid just sleeps lighter when they have the alarm on because they know there's something there. So I think they are more aware of their body. But if that gets them to dry, that's a good thing.
Absolutely. And I always tell families too, if the first couple weeks you're like, it's not going well, just put it in a drawer and pick it up next summer or something. I typically recommend it over the summer when we have longer periods of time off of school. But it's tough. I mean, it takes someone to get that child out of bed.
And of course, we get asked lots of questions or are presented with lots of strategies that maybe aren't good ideas. Are there things that you specifically don't recommend when a parent and a child are trying to achieve nighttime dryness?
Sometimes you'll have people that will come in and say they've tried waking up the child to go pee during the night. I have not seen that be very successful. I mean, they're not either awake enough to even know they have to go, and they're not waking up from normal cues of when they have to go either. So even if they might have peed when they wake them up, they may still go fall asleep right after and still wet the bed after. That's not been, you're not looking at natural triggers and cues to have you do that. So that also is very disruptive to everyone's sleep. The parents setting alarms to kind of wake the kids up, then they don't sleep well and they still have accidents for it too. I try to encourage not doing that unless it has worked from the past. That's not a suggestion I normally give. I try to have them stop doing that too.
Yeah, I do the same unless a family says, I have a couple families that the dad works and gets off at like 1 a.m. and he'll say, oh, they were dry when I took them to the bathroom. And I'm like, great, let's wake them up at that time. And then we try and stretch that interval so that you can kind of get the body used to maybe holding a little more urine overnight. But I also don't recommend waking them because you're not waking them when they're urinating. You're just guessing when they're going to go.
It's kind of that Band-Aid solution,
Exactly.
kind of like the DDAVP. Yeah. Do you guys have any thoughts on like kids wearing an overnight diaper versus underwear when they're trying to be dry at night? Underwear with like a pad under them or something. Do you think there's any benefit of switching to underwear sooner? Some parents will try that.
I don't know if it makes much of a difference. I mean, there are some children that may, if they know they have an overnight diaper or pull-up on, they may just pee into it and then not really care. And then the impetus of having underwear may be a motivating factor for them. Maybe the sensation, like you were saying, is a little bit different. But I tell families whatever is easier. I mean, this is not something that's like a very easy fix or a very quick fix. So if you're going to be doing laundry every day because they wet the bed, but you can save that by using like an overnight diaper, that might be the way to go instead. So try and just manage some expectations and kind of what's easier for them. And if that works, that's great. I don't tell them to try this versus that because I think it makes no difference.
Yeah, I agree. Most of them when they come to clinic, they're like, we tried going without a pull-up for 3 months and we ruined 3 mattresses. I'm like, it's not worth it. Let's put them back in a pull-up because it's likely not making a difference on them being awake or able to wake.
Are there any other resources you guys generally point families towards? Any apps or books or anything like that you found that are useful, or websites?
Sometimes even just having them try to keep like a log of like what they intake volume-wise, what they're eating, what they're drinking, and then when they pee. Because it's very easy to assume that your child is going at a certain time or drinking different things, but if you actually keep track of it, like, oh, you drank a 20-ounce soda right before bed. It's no wonder that we then had 20 ounces a year and that had to come out from there. And just seeing what you're drinking and when, and what you're eating also can be a big contributing factor. Or how often they're peeing during the day. If a kid pees just once a day, something very infrequently, probably try and get the daytime stuff better as a focus first, again, before you do nighttime things.
Yeah, we use diaries on a lot of our patients. I think it's very beneficial because oftentimes you'll find that they drink a lot of fluid after 4 p.m. And so trying to get them to move that to the morning helps. And sometimes those are the simple things that you can get them. Plus, I think when we do these diaries, we have them urinate and we can see how much are they holding. If they're holding a small amount, they're probably not going to hold a whole 8 hours worth of urine overnight. So really having them increase hydration during the day so we can get that bladder to stretch a little bit to hold more urine so it will overnight too.
And then part of that with the diaries, we give them like a Bristol stool chart to kind of describe what types of poop are and what is considered constipated versus not. And having parents be involved like, oh, maybe they poop once a day, but it is balls, which is a terrible, severe constipation.
Yep.
From that
The Bristol
so,
stool chart always gets a good response in the office.
Yeah.
As far as kids with developmental disabilities of various types, do you have any advice for helping those kids to be dry at night, other than just reassurance that?
Most of that, I think, is very much reassurance, but then just communicating that it may take longer just because if everything else is delayed or other things are delayed, like you're saying, that sensory component is probably delayed as well. And if it's isolated bedwetting, that's not something that's going to cause problems. So it's more reassurance and just saying it may take longer, and that's okay. And just trying to see what's the most convenient thing for families. So it's trying to have something like that. Probably would say don't use underwear. Maybe use an overnight diaper instead just to capture urine. So it's easier to manage from that too.
Yep.
Yeah. And I think too, sometimes with some developmental delays, their toileting is a little different anyway during the day, and so making sure they're just on a good schedule during the day so that they can empty their bladder well. Those are the hardest because I think, you get to a certain age, you think they should be dry overnight. But if there's any delays, I always say, I don't know when they're going to be able to do that, but, we can try and help as best we can, but they're tough.
Okay. And at what point would you guys recommend that we refer to our local specialist?
For this, it depends on either the motivation from the parents and the child. It depends on the comfort with either prescribing medications and C. These also can take some time to talk with them too. So maybe families just want another discussion point. Most times we go over the same things the pediatricians talked about, and they're just like, families say, we just wanted to hear this again from somebody else from there. As long as it's like a primary bedwetting, there's not a lot of need to necessarily refer to urology unless either the parent's interested or it's not able to kind of talk fully through with them from the normal clinic visit. I don't know, what do you think about that?
Yeah, I would agree with that. Or if you've tried everything, sometimes they come, they've been on DDAVP, they've tried the bedwetting alarm, and nothing's working. Sometimes we will spend a little more time to kind of get into that and say, well, you only use the alarm for a couple days. Or I see more pediatricians that are starting them on bowel programs, which I think is great. And they're like, well, we did it for a week. It didn't work. I'm like, well, it's probably not going to work that quickly. And so just reassuring them that continuing all of this will give us the best chance for success for that. I think sometimes they want to hear it from us. Sometimes, too, if they call into our office, our triage team can help troubleshoot some of that. If they're struggling with the bedwetting alarm, if the medication's not working, we can kind of tailor, maybe they're not taken at the right time, and just kind of give them a little bit more information on that.
Okay, that's all I got. Anything else you guys want to talk about?
I don't think so.
Okay.
Do you want to talk about MOPS?
Have you heard of MOPS?
I don't think so.
So
Not
MOPS
in a
is-
bedwetting standpoint.
Well, so there's some information out there, but MOPS is like where you do enemas, and you do them for so many days, and then like if you achieve dryness, then it's this whole protocol. There's a book you can buy, and it talks about these enemas, but basically you're just making sure that rectum is empty, and then if they have an enuresis episode, then you do an enema that day to empty it, and so that you're trying to make sure that that rectum's empty. And there's actually a lot of success in a lot of like social media on a lot of pelvic floor therapists use that, and they have seen great success in getting kids dry overnight because you're emptying that rectum before bed.
Just harps on the constipation
Yeah.
management more than anything else.
Look at his
Okay,
face.
yeah.
But again, trying to talk with families about, we're going to start enemas on top of everything else. It's
Yeah.
not
Wow,
always what we're seeing
that is
all the
not
time.
something I've heard of.
Yeah.
It hasn't come across my desk.
Yeah. Well, I actually had a little one, I think she was like 6, who I did a clean out with rectal medications, and she became dry. And I was like, wow, I think when you really empty that rectum, it does make a huge difference. But it's hard, it's a hard sell for families.
Yeah, I can imagine. Well, Katie, Dr. Daugherty, thank you so much for your time this morning. A reminder to our listeners, today's episode is available for CME credit. The link is in the show notes. Today's discussion was guided by the Community Practice Support tool that you can find on cincinnatichildrens.org. And until next time, have a great rest of your day.